Hi, it's David Liew here, reporting from Milan from EULAR 2023 for Room Now. Another great day here at the conference. I feel like we've covered a lot of really interesting territory today. And one of the things I really want to tell you about is something which I think relates into a lot of the discussions that are being had about JAK inhibitors. One of the things that is undeniable about the safety of JAK inhibitors is that it does increase the risk of herpes zoster, of shingles. We know that creates substantial morbidity for our patients. And we want to try and find ways to try and reduce down that burden for our patients. Now, the obvious solution to that is Shingrix and vaccination against, competent vaccination against herpes zoster. It's really something that we should be thinking about actively, especially for JAK inhibitor patients, not to mention the fact that rheumatoid arthritis patients to start with have an increased risk. The questions always come about, does the actual JAK inhibitor itself or methotrexate, both things that could plausibly reduce down the immunogenic response to a vaccine, do those actually impact on the immunogenicity of Shingrix, of herpes zoster vaccination? Some really lovely work presented by Kevin Winthrop today. Data that's within the Select Compare study. So that's within the upadacitinib development pipeline, part of the phase 3 within the upadacitinib development pipeline. But a sub-study looking at about herpes zoster vaccination, about Shingrix vaccination in those patients. So these are patients who were on upadacitinib, who were on methotrexate as well, and looking at those patients, what happens to those patients in terms of their antibody response and in terms of their cellular response. Do they create an antibody response? Is the antibody response high enough? Are they developing a cellular response? And are there patterns within that? So that's the data we saw today in one of the oral abstract sessions, and it's really relieving. Now, I don't think we could fully expect that these patients would mount the same response as immunocompetent individuals. I don't think we can expect that, and we certainly didn't see that. We saw that there was a slightly lower conversion rate, there was a slightly lower antibody titer, and the cellular response was slightly less strong. But having said all that, we saw it wasn't that bad. There's only small reductions in each of those things. And really, when you're seeing 85% plus of patients who are getting Shingrix respond in a serological way, despite their background immunomodulation, I think that's really encouraging. Furthermore, we always think about flares from Shingrix. Only 2 of 95 patients flared in that context. So I think that gives us enormous reassurance as well. So I think all of that gives us this idea that if we're really worried about herpes zoster in our JAK inhibitor patients, and certainly broadly in our rheumatoid arthritis patients, then there's really no excuse not to vaccinate with Shingrix if and when it's available. But plenty more about rheumatoid arthritis and everything going on here at EULAR 2023. You know where to head down on to. roomnow.com.